Okay, shall we start?
Yes. Yes.
Okay. Assalamu alaikum wa masakum Allah bil khair everywhere. Good afternoon, dear colleagues in Arabic as well as all those who are joining this session online. I am Dr. Hilal Safar. I am cardiologist and the chair of RCP Iraq Network and international advisor for the Royal College of London in Iraq. Welcome all for this first scientific activity meeting, which is multidisciplinary team meeting. And we are very pleased that the first meeting is in our lovely Hawler, attended and moderated by a few distinguished professors and consultants in different specialty. The idea is that to have a new mode of presentation of clinical cases for the benefit of all doctors, starting from undergraduate, ending with consultants. As you know, RCP Iraq Network was established for the last 2 years. It is part of the global department of the Royal College of Physicians of London. More than 200 registered members in this network. It has a scientific program which is usually covered the whole year, and we did celebrate the second anniversary last December. We are very pleased that this year we are going to launch the MRCP examination in Iraq, and as it is in Erbil, part 1 and part 2 examination, written examination was just approved yesterday to be in Baghdad, and we are working together to launch the final PACES examination in Iraq in 2 cities. One is in Suleymaniye, Farouk Medical City, and the other in Al-Kafil Hospitals in Karbala. We are going to host a mock exam in the mid of March this year, and inshallah we will have a visit by the Federation of the Royal Colleges to Iraq just before the end of this year. And if that goes well, then Iraq will be approved as a host for the PACES examination for the first time in history in Iraq. We are welcoming any contributions, any ideas, any participations in our program. And I will let the floor to Dr. Amal Marayati to talk about the scientific program. In short, Dr. Amal is a consultant cardiologist. She is the head of the cardiology department, Iraqi Center for Heart Diseases, and she is the head of the scientific activity subgroup. Thank you very much for your attendance. This meeting is broadcast or streamed live on the Facebook page, and it is recorded for further study. Please, Dr. Amal.
Thank you, Dr. Hilal. Good afternoon, everybody. Welcome to the first scientific activity for 2023 of our scientific group in the Iraqi RCP network. Today, we will have a multidisciplinary team case presentation. Will be presented and discussed by a group of our respectable colleagues. If you allow me to present them to you. First, Dr. Safa Al Muktar. He is consultant nephrologist. He is assistant professor of medicine and nephrology at Hawler Medical School. Dr. Deshti Bustani, Assistant Professor of Medicine and Rheumatology. He is the Dean of the Hawler Medical School. Dr. Muzaffar Barazanchi, he is Professor of Medicine and Cardiology. Dr. Rafid Al-Aqidi is a Consultant Interventional Cardiologist. And Dr. Zana Jamaluddin, he is a Specialist of Respiratory Medicine and Pulmonology. Please, Dr. Safa, may I ask you to start the presentation and of the case, please. Thank you.
Good evening, my dear colleagues, my teachers. I'm Dr. Amar, and give you a heads up. The RCP network started 16 years, and we have a program of scientific activities, and it's the first one. Unfortunately, we are dealing with it in the process of distinguished professors. So I'm gonna introduce Dr. Muhammad Sani. He's a therapist and nephrologist who has been caring for the case for me in treating and diagnosing him, but please, Dr. Muhammad Sami.
Good afternoon, dear teachers and colleagues and students. Now I will go through things that we followed up and I will go through the history and we will discuss and I will stop in specific stations to continue our discussion. With the elderly patient, 67 years old male patient, who was known case of mild bronchial asthma from his 30s, which was controlled by single inhaled bronchodilators, referred from an internist because of generalized body swelling and oligoanuria for last 3 days. Actually, the patient was doing well till before 1 month when he received COVID-19 vaccine. And after 2 weeks of vaccination, he consulted his pulmonologist for developing upper respiratory infection, runny nose, sore throat, and high-grade fever. His pulmonologist at that time asked for PCR nasal swab for COVID-19 virus, and it was positive. He got mild chest involvement. He didn't receive any oral or either antiviral treatment, just oral antibiotics in sort of multiple and some tonics like vitamin D and zinc. On the day of 14 of his last condition, he started to be weak, weakness appeared, dry cough, and fever reoccurred again. Patient condition started to deteriorate within a few days by increasing fever, high blood pressure, mainly 118/100, and there was shortness of breath and change in urine color, and also this condition was associated with nausea, and one-time vomiting, but without diarrhea. Also, there was a cough and sputum greenish in color and mild shivering, no any blood witnessed in the sputum by the relative or by the patient. Other part of the history was not remarkable. Patient admitted to the Jean International Hospital in the nephrology and dialysis unit. The vital sign of the patient on admission was 185/105 in both hands in spine position, 97 beats per minute regular. Respiratory was 27, temperature 38.2 degrees Celsius was corrected, and saturation was 92% in room. On the examination of the patient, he was conscious, ill-looking, and distant, shortness of breath, and tachypnea. There was acidotic breathing, pallor of palms and of hands, weak pulse. Sorry, and 82 examination, asterisks, no radio-femoral or radio-radial delay, pale face, stage of jaundice, mild dehydration. No transmitter of external border, and with centrally located trachea. It was leg edema, with positive peripheral pulse. No any skin lesions all over the body, intact neurology. Found by basilar crackles, no wheezing or bronchial breathing. There was bronchial breathing on right middle zone of the chest by auscultation. By component fraction heard over the pericardial examination, no murmur, no any other added sound, and there was soft abdomen without any distension, no tenderness. On superficial and deep palpation, no hepatomegaly, no splenomegaly, and total swelling was present. Now I will give a pause to discuss this case on how you put the differential diagnosis.
Okay, let me summarize what Dr. Muhammad had presented. A case of mild asthma.
دكتور صفاء تسمعني؟
نعم دكتور.
الصوت غير واضح، إذا ممكن يقرب المايك صفاء، المتكلم يقرب المايك.
Presented with gradual deterioration of his general illness. He was vaccinated before 1 month, or 2 days after, presented with fever, tachypnea, and gradually generalized body swelling. Started his blood pressure goes up, and he claimed that his urine was less than 200 cc before his presentation to us by 3 days. So this is the summary of the case. I will just, my colleagues and our students, anybody want to ask anything, just to answer the physical exam. Probably we missed some physical exams that was not important, but if you want to ask about the history, what you mentioned. Yes. No, he gave no history of conditions prior to his receiving the vaccine and on clinical examination and by history, there was no evidence of risk condition in the patient. The first vaccine exactly for 45 days. And then he developed a febrile illness after 2 weeks and then gradually progressed to this patient. But just I want to know what's in your mind and how to approach this case. Yes, that was Pfizer Biotech. Yes. Yes, he was like swelling, scrotal edema. In fact, he was in the state of generalized edema. I think the history goes with that because he was stating that his urine output was very, very low during this presentation and the care to us. Yes. Yes. So
he mentioned one of the clinical findings of retarded friction, right?
Yes. It was a high component on examination. It was vascular scratch, systolic, diastolic.
Is it supporting your final diagnosis of this patient?
I think that when we discuss it, we will come to certain challenges in this. What do you think? What happened to the patient? Vaccinated, got an infection, it was mild to moderate without major involvement of the chest, no oral IV viral medication was given to the patient and started to deteriorate, coming to a critical complication. Yes. Cytoplasm, yes. Cytoplasm and the consequences of the cytoplasm. Yes. JDP, blood pressure accelerated, yes. Dr. was discussing that probably something happened to the heart, probably from the infection itself or the complication of the vaccine itself. So probably heart involvement after COVID is the main presentation, which could be associated with macrophage or the storm syndrome that happens with COVID, which affects multi-organs, the kidneys, the heart, and probably even the brain will be affected. So, yes.
I have to comment. Actually, it is well known entity. We have what's called post-viral cardiomyopathy. And during seasonal influenza, we face patients with severe heart failure, dilated cardiomyopathy after 2 weeks of flu-like illness. So, as a COVID-19, which is a type of, and now it become like a seasonal influenza, it could be a complication. As far as we have millions of affected, so we have a certain percentage, low percentage, because of a very bulk of infection worldwide. We saw dilated cardiomyopathy due to COVID-19 may be an explanation for the story of this plan. This is my limited experience. This is that I think.
I think the most important differential diagnosis in this patient is the vaccine-induced mental illness, and it is well known, and it is common, especially in Pfizer with Pfizer, more than the border can follow that. Border has the 75 days, mainly with the messenger RNA vaccines.
The vaccine is well associated with certain
Yeah.
Moderna and Pfizer was important
Because they are messenger RNA vaccine and
your comments about the problem. Yes, I will get to listen. What our comments about this oligonuria? You know that heart failure, myocarditis, when it was caused by the infection that has been presented by the slide by Dr. Ahmed. We don't care now which one is causing that because both of them can overlap. Vaccination and the disease itself can cause heart involvement, kidney involvement, and neurological involvement. So what about the kidneys? You know, we are facing now a really critical patient. Yes, passing no urine, with heart involvement, not breathing, and there was a friction rubber, pericarditis, which means that they are facing some probably renal problem, concomitantly with the heart problem and the respiratory problem at the same time. So I will go through the investigations that we require in this patient. We will go through the complete blood counts and the urine sample.
Thank you for your comment, but I think when you come to a big complication like myocarditis in a patient with COVID, the most common cause is COVID itself.
Yeah.
And it's not so it's more common with myocarditis. So the first diagnostic put it should be COVID myocarditis.
Usually 98% of the modern myocarditis, vaccinated myocarditis are mild or self-limiting. There's no to the mild.
Yeah, I agree with
98%
both of
are
you.
mild.
Yeah, both of you, it's more common to have an environment that is due to acute COVID infection than but still it's an issue and issue of concern. The vaccine, especially this patient taking 5 of them. And this is the point. And I think the time is typical for the presentation. Regarding the renal involvement, this patient having cardiorenal syndrome. As maybe part of multi-system inflammatory syndrome. I guess.
Probably you see it in the storm, probably you see it for sequencing and heart and involvement, etc.
Yeah.
Thank you, Dr. Lavan. So we will go through the investigations of this patient and we will see what's happening and we will take the opinion of the ECG by my colleagues.
بس أكو دكتور هلال يريد يحكي.
Yes.
دكتور صفاء بلا زحمة عليك، الصوت مو واضح بالنسبة للأودينس، يجوز بالقاعة يمكن واضح بس المايك خلي يكون قريب على فم المتكلم حتى ويتكلم بصوت أعلى حتى يكون الكل يشاركون بسماع الهيستوري. الشيء الثاني المصور خلي ياخذ زوم على المتحدث حتى يبين إذا يتكلم أقلها we can read the lip movement. فالمصور خليه يكون زوم ويا المتكلم اي واحد نعم حتى تكون
زين يجي
شويه صوتك اعلى دكتور محمد حتى الصوت يوصل اوضح لانه اكو صدى عندكم بالقاعه. شكرا.
Can I continue for the case?
السلام. Not moving?
Yes. Yeah, about the investigations of the patient, as we admit the patient to the hospital in the nephrology department, about the CBC and the blood film was normal. There was leukocytosis with normal platelets. The ESR was 78 and the retic count was within normal corrected. The general urine exam was deep yellow color. Normal specific gravity, 3+ proteinuria, 3+ hematuria, negative for ketones and sugar. The serum creatinine was high, 6.1 milligram per deciliter, blood urea 197 milligram per deciliter. The liver function test was normal. The serum potassium was 6.8, and the serum sodium was 128. The serum calcium 7.5. Magnesium 1.5 and the parathyroid hormone is 81, vitamin D3 was 15, the thyroid function test was normal, and the actual blood gas was the pH was 7.2 and the bicarbonate 16. The virology screen of hepatitis B and C and HIV by PCR revealed negative. And the ECG, any comment? ECG or the investigation?
Basically, you can see here clearly the patient is tachycardia with the diffused inversion. The axis is normal. This is will support the diagnosis of myocarditis. Yes, it's common.
Yeah, it's not specific with the work spot.
Yeah, I agree with the tone number. But I think the exit is somehow this is not normal anyhow. There is the Y17 version, symmetrical everywhere, and most probably it goes with the myocarditis. There is some ST elevation in the V2 and V3. And with bypassing that, to say ST elevation with T inversion. So this is may goes with the coronary insult. nobody can tell. I don't know whether we have an idea about the troponin. Ischemic hemorrhage seconded in this case.
Ischemia or myocarditis can be done in the future diagnosis of ECG. Okay, thank you.
Safa, I have one point, please. Safa.
One second. نعم دكتور هلال.
We heard in the history that this patient got his illness a few days after getting vaccination. Are other members of his family receiving vaccination at the same time?
Yes. They took the vaccination. The young boy, he took the vaccination with him just only in the same time with his father, and he's I think he's 28 years old, but in the same time with his father. But others no, they have a different time periods for taking vaccination.
And they didn't develop a similar problem. Only him from the family.
Just in the family still, or just in the family.
Okay. Another comment about the ECG. Greeting to Dr. Muzaffar, Dr. Rafid. I think there is poor R wave progression. It's not very good. Poor R wave. It seems to be as if it is a diffuse. I agree. Diffuse myocarditis or that lead to such a decompensation. And do you have the level of his troponin?
Yes, sir. I will next investigations I have this.
Okay, sorry.
Okay. About the echo comments, it was mild pericardial effusion, pericardial thickening with ejection fraction of 40%, global hypokinesia with left ventricular hypertrophy. The troponin was 0.12 and the CKMB24. The bleeding profile was normal. The ultrasound of the kidney and abdomen and the kidneys revealed enlarged echogenic kidneys with early loss of CM differentiation with mild ascites. The CT scan of chest, native CT of the chest, right side middle lobe consolidation without any infusion or ground glass of capacities. Features suggest of bronchial pneumonia. The summary of the history: the elderly man who received COVID-19 vaccine and got infected by COVID-19, atypical viral pneumonia, admitted to the nephrology department with severe generalized edema, oliguria, and severe hypertension. This is the summary of the history. So, how can we put also differential diagnosis after this?
I think that initially when we discussed with my colleagues, the differential diagnosis has been put by them. It is an acute COVID infection, well, probably vaccine-associated complication. Or both of them, we don't know what's happening to this patient really. So I think that the patient got a multi-organ involvement by a post-COVID syndrome. The heart, the kidneys, and were involved together. And we can name it a systemic endocardial syndrome, not the other way around. It's not heart failure leading to acute kidney injury. It's a simultaneous involvement of the heart and kidney in a single pathogenic problem. Probably the pneumonia that was seen in the CT, it was a right middle of pneumonia, which is not, I think, it was a classical syndrome. I think most of the community-acquired pneumonias have a right middle presentation, and for that reason, I cannot say that was a healthcare associated or the patient was not immunosuppressed. Was not receiving steroids, I think that diabetic. So namely, it was a feature, as I suggested, of a community-acquired pneumonia. He was at home when he came with that. So a bacterial pneumonia with a history of COVID infection, heart and kidney involvement. We will see through the investigations for this patient, and I think that if you want yes, probably I would think yes, the place of long-standing asthma, probably the patient at the same time is on the people to receptor blockers. They have a mild, higher incidence of vasculitis, mainly the eosinophilic granulomatosis, which was called before Churchton syndrome. And it has a presentation like that. Characteristic recently global and 5% other features. So the long history of asthma, I think that we did not do the serum IgE level, sorry for that patient. Probably What is posed now, and the question, is the history of mild asthma is related? I think yes, to increase the mortality. If it is just involved, but it has prior history of asthma, you know, probably pneumonia will be very aggressive. Albeit any type of pneumonia will compensate his lungs. Do you have any ideas, Anna, how to put the importance of this long-standing asthma on this patient's history?
Yes, of course. Myocardial involvement in patients with EGPA is still as one of the common cause of mortality in patients with EGPA. Yes. This patient has features echo findings, even ECG findings, and clinical examination findings, and reveals that the patient has some sort of myocarditis or cardiomyopathy.
So vasculitis should be put on.
Yes. Absolutely, we need ANCA levels in general, plus total IgE level, and absolutely is not required for such a patient to fulfill the criteria for the diagnosis.
Yes. Okay, so please proceed with that patient, please.
Yes, sorry, I want to ask about the CRP and 730.
And it was high.
Yes.
Very high, yes. I mentioned the CRP is 76.
And he died not?
No, I didn't review.
One of them were high. The problem in this presentation was so rapid that we were just to save the life of the patient, we started.
I don't know the comments of my teachers will start here or I will continue. Yeah, our management plan started after 4 to 6 hours from the admission to the hospital after the investigation has been appeared. As a direct indication as a hyperkalemia and acidosis start dialysis for this patient, they are dual lumen catheter, internal jugular vein with 2 hours with 2 liter of filtration. And for the second day of admission, the patient shortness of breath. It's somewhat better still by basal filtration and mild edema was present. We decided for the second session of the dialysis and we sent for some investigations, which for the next 24 hours the investigation was like that. The rheumatoid factor was negative, the ANA was normal, antidouble stamina was normal. As I mentioned, hepatitis B and C PCR were negative. The C ANCA was high, there was 76 positive with high titer. And the P ANCA was normal, negative, anti-GNB, CH50 complements were normal, not consumed, and the COVID PCR was negative. So here the second step investigation was negative. Yeah, it was negative. And anti-GNB antibodies were negative.
Diagnosed for fasting disease also was repeated twice.
Yeah.
I will mention that these investigations were repeated 2 times just to confirm that our line of management will appeal after presenting these the complements is normal, the PCR for COVID is normal. So I think from this slide the importance of being the complements were normal, the C ANCA or proteinase 3 ANCA was high titer positive, the MPO for the wider peroxidase was negative. So I think that with the general urine exam showing RBC cast, hematuria, that the diagnosis is settled with that slide, that we are dealing with a case of ANCA positive, C ANCA positive vasculitis, probably related to risk illness, COVID-19 or the vaccine.
Yes. So on the third day of the admission, the patient appetite returned and the edema and the shortness of breath is better. Still, he is oliguria. Pulse dose of steroid started after the positivity of the C ANCA. Methylprednisolone daily once for 3 days. And the second day of the steroid, his urine output increased and the renal function decreased mildly and the serum potassium level normalized without any cystotic breathing. And we planned for the native kidney biopsy at the 4th day of the admission.
Again, I will mention kidney biopsy, native kidney biopsy in an uric patient is not an easy procedure. Overall, the indications for kidney biopsy and kidney injury is very scarce. Nephrologists usually avoid doing a biopsy. I think even without the biopsy, we have done the biopsy just to guide our treatment. You know the patient is oligoanuric. So I want to say for a reversibility for this patient, since I have no comorbidity, is not basically hypertensive or diabetic, and he had no history of cardiovascular disease. So for that reason, academically, we started steroid therapy without the biopsy. Once the patient stabilized after these 3 doses of steroids, he was gaining some appetite, he was stable clinically, his urine output started to reach 400, 600 cc, and we go for a latent kidney biopsy, and we will show you the results. Yes.
Yeah, this is the HNE and the fast stain for sclerotic capillary stops, the star area with a cellular crescent.
I think it's very obvious here.
Yes, this is the arrow was crescent.
Classical glomerular collapse.
Yes. This is I asked for the pathologist to send me the slides. Actually, this is the crescent, which is by the arrows, and the stars are the sclerotic area. And in this frozen section, the 2 glomeruli with circumferential cellular crescents here and here, and there is capillary necrosis here in the star area.
So we document the diagnosis of presenting GN by the pathologist when the surface area and the glomeruli, when the crescent is involved in more than 50% of the appearing glomeruli, that will be the diagnosis of crescents. However, by 20-30%, we will not tell that the patient has a crescentic glomerulitis. So obviously, by a low power, there was a circumferential crescent and pressing on the top, as Rosanna says, probably leading to total collapse of the glomeruli. So this was next. Yes, this is of course when you document our diagnosis, the immunofluorescence is available in our centers, in Sleimani, and the immunofluorescence, as I mentioned, you have a clinically patient with CNK positivity, and from its name, they put it as posi-immune. What's the meaning of posi-immune? In the immunofluorescence, you should not see antibodies or deposition of immunoglobulins that will take you out of the posi-immune vasculitis. If you see C1q, C3, C4, IgG, IgM, it will be turned a full house immunoglobulins, and a diagnosis of crescentic lupus will come into practice. But this patient, classically, if you see that the immunofluorescence for IgA was simply negative, IgG and C3 minus 1 plus. So it's a classical immunofluorescence of posi-immune crescentic GM.
This is the description of the biopsy which was sent to the lab. HNE pass and trachom stains performed the biopsy, 100% renal cortex without glomeruli and the blood vessels. HNE stain performed on cryostat section and revealed a cortex of 8 glomeruli and 1 arterial and arteriolar cross section. There are 2 globally sclerotic glomeruli, 4 glomeruli with cellular circumferential crescents associated with underlying capillary necrosis, and the other 2 glomeruli look normal.
So if you think out of 8, if you see this biopsy, concentrate on it. This is a cellular crescent, not fibrocellular. It's not a fibrotic crescent. Sometimes the pathology will guide us to the magnitude of immunosuppression that we use. So the presence of cellular crescents, that means that we are diagnosed an early case of crescents. So management is necessary, and aggressive management is necessary, because the patient is already anuric. And if you see the immunofluorescence again, I will concentrate on the posi-immune non-specific.
There is 3 real, yes. And the comment was rapidly progression was in more than 50% of the glomeruli. 4 out of 8. Yes.
Yes. So
Yes.
Can I ask you what will be the management for this patient? The CT scan is showing pneumonia, myocarditis, quite an ECG and echo findings, and a rapidly progressive GN with crescents. So can I have some options about how to manage this case?
From the echocardiography, there is also hypertrophy level trigger. So it's possible this patient is was hypertensive and diagnosed.
Yeah.
And patient with hypertension and structural habits, they are more liable to develop complication, cardiovascular complication.
Can I believe that the management should be directed now at which organ? And this is my This is my question. How I will start to manage? What is the most important organ now in this patient's involved?
Of course.
Yes.
I think the kidney is the most important, and secondary is the heart and this patient.
So any overlap between the two, if I will manage, do you want to give some important medication
Definitely, we cannot
for
be.
his heart failure? What do you think that I should put for the heart for this patient?
This patient needs to be put on first diuretic.
Yes.
This is for the treatment of the heart failure, and ICU first. Steroid is found also to be useful in patients with COVID myocarditis.
Yes.
May help, and digoxin to be avoided.
Yes.
It's important to be avoided, and also beta blocker station to be avoided until you control heart failure. So the treatment now, marginal heart failure, steroid, diuretics, and ICU inhibitor is the best.
Yeah, regarding the heart condition in this patient, is eminently stable in this patient. So we should direct our treatment to the guideline-directed medical therapy. And that's, I support the idea of Dr. ظهرا, that the use of diuretic, beta blocker, IC inhibitor, it is a question mark in this patient.
Yeah. It should be different ideas about the use of inhibitor.
IC inhibitor.
We need some control of potassium and then to get away from the therapy.
IC inhibitor, yeah. Yeah.
Regarding his chest, Dr. Zana, what do you want to do for this patient during this period?
Yes, the only thing that we do for the chest is just general management of the committed acquired pneumonia in this patient.
So you want
for this patient.
So you want to treat him as a committed acquired
pneumonia, complicated acute elevation of the patient. The patient has here.
So what do you prefer that to be given for the patient?
For such a case, I don't know the exact creatinine lately, the last one creatinine rate.
What on the analysis initially? There was no urine.
Yes, according to the American Society, you have to recommend monotherapy in this patient, definitely.
Yes.
Now we are treating this patient pneumonia as a case of immunocompromised, not immunocompetent in this patient.
Yeah.
So the patient is immunosuppressed already, and we have to put the patient on immunosuppression apart from the steroids.
So,
but I have a question: do you prefer to start in this patient immunosuppression in the form of cyclophosphamide rather than immunosuppressants?
Yes, I will come to that question. So, Dr. Zana is preferring to use a
دكتور صفاء تسمح لي
acquired pneumonia.
نعم دكتور.
No hospital acquired pneumonia or healthcare associated pneumonia is to be defined in this patient, and you prefer to give antibiotic therapy throughout. And you need, of course, to manipulate according to the culture and sensitivity results.
Actually, patient with going to acquired pneumonia, we don't need any culture. It's so sensitive. You are just taking the empirical. And we are waiting for the
result. We have started the loading dose of ticagrelor with the patient for health. And we have given another probably carbapenems and ticagrelor. Just we are, that we are putting a internal jugular catheter and the risk of infection will complicate the management. So we have a heart management, we have respiratory management,
regarding thromboprophylactic in this patient.
Yes.
Yeah.
What do you prefer, sir?
And this patient, as far as this patient having, kidney problem and the related serum fatty, so it's better to go with unfortunately deeper.
Yes.
Okay.
According to this.
According to, we can use the low dose continuous.
Prophylactic or you need a
prophylactic, but we can use the low dose. That is, say, IV infusion.
Yeah.
Not necessarily we give interrupted doses, or we can use interrupted doses and purchase heparin 3 times a year.
Yeah.
Okay, so this is the.
So,
توصفها إذا تسمح لي. توصفها. I just want to comment, please.
Yes.
يعني excellent discussion ولو الصوت مو كلش واضح يمنا، لكن اتمنى يعني البوست جراجويت تريني يشاركون بالنقاش وتبدي بالاسئله لهم حتى نشوف شو الابروش مالتهم. ديفنتلي احنا الكونسلتنت يعني هم الماستر اوف everything. نريد نشوف البوست جراجويت تريني ايش راح يحكون والمانجمنت مالت الموضوع. النقطه الثانيه يعني يا ريت اكو ستيب وايز ابروش للموضوع، لانه تعرف اكو اندر جراجويت، اكو بوست جراجويت، اكو كارديولوجيست، اكو نفرولوجيست، اكو اذر سبيشاليتي ار جوينينج ذا ميتينج. فانا اريد اثير بعض التساؤلات، مو بالضروره يعني بس حتى تكون واضحه للباقين. اولا البايوبسي يعني why do you think it is a vasculitis and you did a vasculitis screen? This is the first question. The second question, the biopsy, does it strengthen your diagnosis of being have a vasculitis so that you started a high dose steroid in this patient? The third thing is that what was يعني ما كلش سمعناها واضحة حقيقة. What was the antibiotic policy in this patient and what are the bases on choosing of these antibiotic? And probably Dr. Rafid تطرق للنقطة الأخيرة about anticoagulation in this patient. So please, if you can start with the postgraduate trainee to give their idea and any suggestions, and then to address these questions. Thank you.
Okay, who can address the question by Dr. Hilal or the postgraduate, Dr. Safa?
Just I want to ask about, okay, we are definitely believe it's a case of ankylosing. So what it's related to COVID-19. So what's the rule of COVID-19? It's a trigger, the cause is an exacerbation by COVID-19, or it is a just molecular mechanism. And this question, next question about the comment that Mr. Rafid. What's the indication to use anticoagulation in this case?
Thrombogenicity of COVID itself has been proven that thrombogenicity is a major pathogenic factor in the pathogenesis of thrombus associated any organ failure. It could be the heart, the kidneys, and the brain. Major pulmonary embolisms has happened in acute decompensated.
Yeah, but this case, we are not sure whether it is due to an acute COVID, whether it's a vaccination, but he is not in acute state of COVID-19.
I would respect you. Because of the concerns, they said, why do you mention vasculitis? For all of us, even the undergraduates, any case of acute kidney injury with a urine exam showing hematuria and proteinuria, so it should be the glomerulus is the problem. This is not a pre-renal and this is not a post-renal. This is a renal glomerular. The high titer of C-ANCA is going with that the patient has a vasculitis. The light microscope of the biopsy, more than 50% of the glomeruli seeing a cellular crescent. And the biopsy, as I told you, just to have the way for the nephrologist, do you want to be aggressive? For example, if the patient's biopsy showed more than 50% of the interstitium is fibrotic, that's to say it's an end-stage kidney, you will not go for immunosuppressive those patients. Probably I will use steroids and stop. But the presence of cellular crescents will tell the nephrologist and any treating physician for that patient that I should be aggressive with them in the hope to save the kidneys. And the presence of these crescents on the biopsy, crescentic GN is not a specific diagnosis. It's like anemia. You should go for the cause of the crescent formation. So ANCA-associated vasculitis with crescentic GN means an advanced presentation. So it's not necessary for the C-ANCA to come with a crescentic GN. It can come with a necrotizing GN or a focal segmental-like presentation on the biopsy. The presence of crescents and cellular in the biopsy of this patient mandates an aggressive immunosuppression. So, as Zana asked me, some prefer to use Zindoxan and some prefer to use rituximab for those patients as initiating. According to the TAXIVAS trial, the only way to treat patients with ANCA-associated vasculitis is to use high-dose steroids and then cyclophosphamide in sessions over 6 months. The role of plasma exchange was less in the last literatures that we don't use plasma exchange prophylactically in our patients because many trials has proven the addition of plasma exchange to steroid and cyclophosphamide therapy does not change the future outcome of the kidney. So for that reason, we did not use, and for more information, there is no head-to-head trials comparing MabThera, rituximab, with compared to Indoxan for the treatment of this type of presentation of associated vasculitis. What is written and what is the best approach is the use of cyclophosphamide. Albeit, it was a great challenge to me. There was an active bacterial pneumonia, and there was an active involvement of the heart. But after steroid therapy, I decided, and after seeing the biopsy and discussing with the pathologist, I started cyclophosphamide 1 gram to be given. And after, it's 3 weeks just to begin to act, and the patient started to improve on cyclophosphamide. The second dose of 1 gram was given, and the course completed to 4 grams. And meanwhile, the patient presented with a phase of some polyuria, improvement in his heart condition, improvement in his cognitive function, and improvement in the general well-being. After the second dose, dialysis was stopped. He was having a urine output of about 2 liters per day. And after the 4th dose, when we reached the 4th dose, the patient was stable on the serum creatinine of 2.5 milligram per deciliter. He was well, and we removed our double loop catheter, and we are planning to continue the Indoxan treatment up to 6 courses, and after that, leaving the patient on continuous therapy, steroids and azathioprine for another 2 years. So this was our management, and this was our plan. We have successfully treated in an elderly, more than 65. We successfully managed the patient, and so we get a very good result that the patient was dialysis of albeit living with a bad kidneys in stage 3A CKD, but it is the goal of treatment of this patient is to save his life first and stabilize the kidneys, stabilize the heart, and stabilize the lungs. It's just X-ray after 1 month was nearly normal. His echocardiogram improved. The ejection fraction got 56. After that, there was no more motion abnormality. And I think that this immunosuppressive therapy was aided by my colleagues that steroids are even beneficial for the heart if there is an immunological involvement by vasculitis, for example. But I think that when we go to the literature about post-COVID or post-vaccination kidney, heart, and lung involvement, we will see that up to 6 cases still now reported only, resembling our case we discussed today. These 6 cases, 4 of them are managed by rituximab, and 2 of them were managed by cyclophosphamide abroad. But I don't know, my rapidity of deterioration of this patient has been led to us as a team to use cyclophosphamide and not rituximab. Probably I told my colleagues when we were managing them, there is some folks that rituximab therapy with the vaccination that probably up to 1 year, if you blunt the CD20 antibodies by rituximab, would be more problematic than cyclophosphamide regarding the activity of the vaccine for the future.
Yeah, it's against use of the COVID-19 vaccine
with rituximab, yes. So these concerns have led us that we should use cyclophosphamide, and we treated successfully this patient.
Dr. Safa, another question, please.
Yes.
How frequent do you recommend renal biopsy in those patients with a sudden deterioration of renal function post-COVID and a picture similar to volume overload that this patient was? And how frequent do you did biopsy in such a patients?
Yes, very nice question, sir. I think the treatment, it's not a very complicated idea. The urine exam will tell the treating nephrologist about where to go. If history-wise, that the patient was hypertensive in the ICU for more than 7 days on a ventilator with a urine exam that is planned, I will put an acute tubular necrosis as a diagnosis for this patient. I will not biopsy him. The urine exam was so active, Mr. Hilal, that mandate us with a high risk to go and biopsy the patient, because we were thinking of a crescentic GN, rapidly progressive GN, due to the presence of this high titers of anti-proteinase 3 antibodies and the active urine exam. The biopsy is here just to decide whether to leave the patient and leave the kidneys to stop, or to start early aggressive treatment just to reverse the crescentic GN. So it was mandatory to be done for this patient to decide for further immunosuppressive therapy. The decision without biopsy is very difficult, Stabila.
شكرا جزيلا. الكاميرا دكتورة بشارة is off, please.
So this was just the first side of my talk. I will go through one slide only, not go for the deep. So next. See, this is a very interesting slide. These are the spectrum of kidney involvement in COVID infection. If you see here, for example, that the medications that we give, remdesivir as an antiviral, and probably other antivirals, may have a direct effect on toxicity on the kidney. So the vitamin C was reported in a very high dose, which was adopted by many physicians and nephrologists to give. All of them, even cardiologists were using vitamin C in a high dose, which was recommended early in the COVID era. So vitamin D, we have a very interesting reports of oxalate nephropathy. And you know that vitamin C increased the absorption of oxalate from the gut. So there was a very case report interesting of acute tubular necrosis induced by oxalate. Yes, remdesivir can cause crystalluria. Yes, nephrotoxic and crystalluria, remdesivir, direct viral infection associated with other glomerular disease, membranous nephropathy, minimal change, focal segmental, and crescentic GN as our case. Collapsing focal, atypical hemolytic uremic syndrome, rhabdomyolysis associated myoglobin nephropathies, ATN as any patient with hypotension or dehydration, or the prerenal azotemia. So this is what you have been seen in clinical practice. It's a very interesting review in the Clinical Kidney Journal, about 64 cases of proved kidney involvement. Biopsy was not done to all patients, apart from when there was a suspicion of glomerulopathy. For some centers has been proven a usual ischemic acute tubular necrosis. So prerenal tubular injury, rhabdomyolysis, thrombosis, collapsing GN, glomerular, crescentic, membranous, and oxalate nephropathy. This is very interesting. Just to summarize, what would happen to the kidneys if you have an acute COVID infection? Another slide.
دكتورة بشارة السلايدات هذه شيريها. We are not seeing it.
They claim that if you are genetically susceptible to acute kidney injury, probably the COVID will do it in a certain patient more than the other. This is the carrier state of ApoL1, which is a gene carried by the African Americans. And God has changed their genetics just to not to be infected with falciparum malaria. So Africans are protected by nature, by God, to acquire ApoL1 to protect them from malaria. At the same time, this nature-associated ApoL1 carrier is associated with chronic kidney disease. Thank you. I will not elaborate more than that. Generally, just my slide showing what is the spectrum of involvement of the kidney in COVID-19 infection. And I will give to Dr. Muzaffar to have some notes about cardiac involvement in COVID.
Is it this one? Oh.
Know that COVID-19 or SARS-CoV-2 infection is not only respiratory disease, it's a multi-system disorder. Next one. So it is a respiratory illness which can cause serious complications, including or kidney failure and vascular complications. So angiotensin is usually the COVID-19 one. It causes the infection through the invading the attaching to the ACE2 receptors in mainly the lung, but also these receptors are found in the heart. So cardiac involvement is also common in patients with COVID-19. The cardiovascular complication, one of the major causes of mortality in patients with COVID. Not only they die from respiratory failure or diffuse lung respiratory syndrome, many of them they die from the cardiac complications. And two early studies on COVID-19 report that 20 to 28% of the patients going to have cardiac injury associated with cardiac dysfunction and arrhythmia. So it's a big number. Although exact numbers that we are not available yet. Accurate, we don't have accurate how much there are cardiac heart is involved in patients with COVID. But from the investigation, laboratory, and from the imaging modalities done for the patient with COVID, they found that cardiac involvement is common. Cardiac injury is more likely in male patients, in elderly, in patients over 60, and patients with comorbidity, previous diabetes, hypertension, previous chronic kidney disease, and chronic lung disease, and obese patients. So in this our case, the patient was possibly he was hypertensive also, and making more liable to complication. Myocarditis is tenfold higher in patients with unvaccinated and that compared with the vaccination. So there is to talk about the vaccine-induced cardiomyopathy myocarditis, but the most is rare, 1 per 10,000 cases, and usually it's a mild self-limiting. But the benefit of the vaccine is much more. It can reduce the cardiac involved myocarditis much more. And mRNA COVID vaccines rarely cause myocarditis, especially in the young adult. The putative cause of cardiovascular infiltration with the COVID usually is due to firstly in the acute phase of the illness, usually due to the viral infection and invading the cells, lungs and cardiac cells, which cause cardio apoptosis and cardiac cell injury. But later on, even in the usually within 2 weeks, the virus disappears in the blood, 2 to 3 weeks. And because the other thing is the autoimmune reaction to this virus, which may be augmented, and it's a severity in some people causing cytokine storm. And this is maybe the cause of the myocardial and renal complication. Extreme physical stress also sometimes misconstrued cardiomyopathy in some patients. Another complication, myocarditis, most common. Some patients with COVID, they develop acute lung syndrome and myocardial infarction because of that, blood puncture and coronary artery obstruction. There are also the pulmonary angiopathy and hypercoagulability is well known, and this many of our patients with COVID, they develop acute pulmonary embolism and acute right side heart failure and died from this complication. And of course, respiratory distress syndrome. So as we mentioned, we did the cardiac complication usually through the ACE receptors may cause acute coronary syndrome, heart failure, myocarditis, arrhythmia, and venous thrombosis, or directly through indirectly through the inflammatory process that cytokine storm. And here you can see that the cardiac complication, which includes right ventricular dysfunction, right side heart failure, myocarditis, arrhythmia, acute and tachycardia and pericardial effusion. And here you can see all this complication in patient with COVID. So the prognostic factor, usual patient with admitted patient usually develop this cardiac complication more common than the asymptomatic or mild cases. So usually the cardiac involvement is more common in patients with very high inflammatory markers, very high CRP, very high and also the lactic dehydrogenase and ferritin. And the presence of these related cardiac troponin and D-dimer and also BNP and proBNP is putting this patient at high risk for mortality. The diagnosis of the cardiac involvement with COVID can be it's important to be put in the differential diagnosis consideration that heart may be involved with any correlation to cardiac propulsion. We check it, it's fine, it indicates myocardial involvement, myocardial involvement. BNP protein is also very important. This patient, our patient, they didn't see that result BNP protein. It was important to be done for diagnosis of heart failure and for the monitoring, what is the response. ECG, we showed in this case, you can see the key changes, and sometimes you can see the myocardial, even the myocardial infarction. Echocardiogram is very important to diagnose myocardial. You can see the direct global hypokinesia, and it's easy, it can be done. Cardiac imaging, cardiac MRI, another tool for diagnosis, and usually we can detect even the minor involvement of the heart, mild cases, asymptomatic myocardial, cardiac MRI, endomyocardial biopsy, the definite diagnosis for myocardial is rarely done. And if the patient needs chronic catheterization, they may do at that time, but cardiac MRI diagnose many cases of the cardiac involvement. Okay, thank you very much.
Thank you. For very it's nice. The whole is for another for a few minutes for Dr. Zana, just to talk about.
Thank you, sir.
I told him 2 minutes. Okay.
Thank you. Thank you, everyone, and good day, dear colleagues. Thank you for the RCP effort for inviting me to such a wonderful event. Actually, they told me to have to.
يبدو انه الكونكشن دكتورة بشارة, the mic is mute please. Just unmute the mic please.
دكتور اعتقد هم جاي يحاولون يحلون مشكلة الصوت. عفوا.
لا هو ده يتكلم لكن المايك ميوت.
Is it better?
Yes.
Okay. You can go. Oh.
So he had been hospitalized in ICU and he was diagnosed with severe COVID-19 pneumonia and moderate ARDS. During the ICU stay, he developed acute kidney injury, acute leg ischemia, AF stroke, esophageal bleeding, sepsis-induced coagulopathy, and finally multi-organ failure. And unfortunately, he died after 21st day of this illness. What happened to this patient? Yes, we know that the COVID-19 is a primary respiratory illness, but this different organ involvement, they should have a pathogenesis. So, as a conclusion, it's a primary respiratory illness with different extrapulmonary manifestations that my colleagues all talked about, including the kidneys, cardiovascular system, hematological system, endocrine, as well as the dermatological manifestations. The pathophysiology of COVID-19 is not fully understood. However, it has been confirmed that SARS-CoV-2 binds to the ACE2, which is the entry of the virus to the host cells. This ACE2 binding is a spike protein of the virus because the virus contains 4 different proteins, including spike protein, nucleocapsid, and of envelope proteins. These are proteins that help, but the most widely used and common used in patients with SARS-CoV-2 is the spike protein 2 type to that enters the cells. Although the SARS-CoV-2 RNA had been detected in several organs at low levels, it's largely unknown until now to what extent these manifestations are the result of direct infection or direct viral injury to the organs. Okay, this is structure, just a review of this structure of the virus. SARS-CoV-2 is a positive sense single-strand RNA virus that contains 4 main types of proteins. We talked about this, please skip it. Next slide. The mechanism underlying disease manifestations are incompletely understood, yet most data suggest that severe COVID-19 results from a combination of either first, immune dysregulation and depletion of the key immune cell subsets, second, complement activation, and the final, which is the most important one, pathophysiologically, is the interaction between the innate immune system and the coagulation cascade that promote inflammatory thrombosis. Definitely, most of the complications that happen in patients with COVID-19, they are immunothrombosis in origin, not due to direct viral injury to the organs. So what are the roles of genetic presentation with COVID-19? You know that there is inter-individual and inter-population differences. Within the same family member, 12 are infected, 2 of them died until they have just anosmia. Why this happened without being the patient on risk factors? For example, I have some patients without risk factors, young age, they died because of COVID-19 and cytokine storm. While other family members, they are just doing well and they just develop a mild upper respiratory infection. There are genetic predispositions to developing severe COVID-19. The most widely studied is the loci containing variants of DPP9 and FOXP4, which is directly linked to the pulmonary fibrosis in those patients. Not every patient with severe ARDS develop post-COVID fibrosis. We are just in 10% to 15%. 85%, despite being really extensively involved in all lungs, they are just skip the after 6 months of the chest imaging shows no residual fibrosis. So those patients, they have the loci containing variants of these two genetic mutations. And the chemokine receptor genes, including CXCR6 and CCR9, sorry, in addition to the TLR3 dependent and TLR7 dependent type 1 interferon induction and complication, these are associated with the patient has loci for these neurotransmitters, they have the susceptibility to get severe COVID-19. In upper airway, you know that the upper airway is the most common organ involvement in patient with SARS-CoV-2 infection. I mean the rhinosinusitis, pharyngitis, laryngitis, and tracheitis. And 85% of the cases, they are mild in origin. The first cells targeted by SARS-CoV-2 during natural infection in humans are likely to be the ACE2 positive and TMPR SS2 positive. This viral entry to the cells is through the ACE2, but with the help of this enzyme, which is TMPR SS2. Nasal ciliated cells express high levels of ACE2 and TMPR SS2 on the apical membrane, despite their low mRNA levels. In most COVID-19 cases, the infection is slightly cleared at this stage, as we said, 85% cleared, through the induction of type 1 or type 2 interferon and the induction of B and T cell responses, I mean the adaptive and innate immune response. However, in some cases, mild, very low percentage of the cases, the virus can spread to the lower respiratory tract and causes pneumonia and ARDS. Pathomechanisms of the portals of entry of SARS-CoV-2, as we said, is ACE2 expressing epithelial cells in the upper and lower respiratory tract. The virus is also taken up by macrophages, which are probably unable to support SARS-CoV-2 replication. Although macrophages likely contribute to viral clearance, virus-containing macrophages also amplify the inflammatory response and may act to spread viral infection within and the outside of lungs. Next, please. Within the lungs, the pathogenesis of the COVID-19 includes 3 mechanisms. First is the diffuse alveolar damage, which is the main pathogenesis of the COVID-19 pneumonitis and severe ARDS, which we call the hyaline membrane disease in the patient with pneumonia. The third is the endothelial injury, the endothelial lining of the capillaries, and finally, a distinctive and specific finding is the large burden of platelet-rich thrombi in the microvasculature. Most of the patients that autopsy studies of the patients died because of the COVID-19 pneumonia show that they have extensive thromboembolism inside the circulation, pulmonary circulation. Not every patient with COVID-19 pneumonia get ARDS and die because of this. You have some specific risk factors for escaping SARS-CoV-2 viral infection and replication in the lungs. For example, immune system of those patients with hyperinflammation. Those who have low immunity, they have more prone to get the cytokine, the infection and organ involvement, while those with the hyperimmune response, they're more liable to get the cytokine storm and indirectly cause the lung injury and not the organ failure. Microbiome in the gut. Sorry, just previous slide. Okay. Microbiome presence in the gut is very important to protect the co-infection with bacteria, and sometimes indirectly, because those patients with low basal diversity, they have the highest risk of progression to the specific COVID-19. As an example for this, initially during the early pandemic, most of the gastroenterologists recommend that please avoid giving PPI in patients with the COVID. Because you know that PPI and broad spectrum antibiotic is not given scientifically, okay, with this microbiome, and this will lead to this disruption of this microbiome of the gut and the lung mechanism that protect the lungs from the severe pneumonitis and ARDS. Another factor is the genetic factors that I don't want to mention more, are comorbidities of the patient, for example, age, hypertension, obesity. Why this patient? Because those patients, they have an overexpression of ACE2 and more carriage of the virus and entering the blood circulation. And thank you very much. I don't want to go more because I have not enough time. Thank you again.
It's working. It's supposed to work. It's not working. اوكي عادي انا حسوي بانيميشن.
ممكن سؤال دكتور زانا. Did this patient do you participate in the management of this patient?
Sorry, I didn't get the question. Sorry.
Did you one of the team who managed that patient?
Yes,
Patient?
I admitted the patient case to the ICU of Razgari ICU. No,
and,
my case that I present a case beginning, you mean?
No. Dr. Safa case.
No, it's not mine.
Okay, thank you.
I'm just trying to forget all the organ involved in my case. I forget this is okay.
Yes, it's working. بس هيشتغل. يشتغل.
اوكي احنا الشير سكرين مبين يمنا البرزنتيشن مع الدكتور رافد واضح.
Okay. Thank you for the attendance and sharing with my colleague of the RCP London Iraq network. For the sake of time, I will skip some slides. Just I want to start with, I want to share with you some of your opinion, raising some questions without voting. Do you advise your cardiovascular patient to take the COVID-19 vaccination despite the concern of complication? Yes or no? I will skip voting. The other important question at the time being in 2023, do you advise your cardiovascular patient for taking a booster dose of COVID-19 vaccination? Yes or no? Let us, at the beginning, let us acknowledge the fact that the SARS-CoV virus 2 can cause, if not may cause, can cause dangerous cardiovascular complication. So cardiovascular complication after SARS-CoV virus 2 mainly mediated by either the direct viral infection mediated by the ACE2 receptor, which binds by the let us say by the virus, the spike of the virus directly, which expressed on the myocardial cell, which cause the myocardial injury, or the systemic inflammation, which is represented by the they increase the pro-inflammatory cytokine, and both can cause myocardial injury or myocarditis, acute myocardial infarction, heart failure and cardiomyopathy, arrhythmia, shock, and cardiac arrest, venous thromboembolism, as stated by my colleague Dr. Muzaffar. Okay, the cardiac injury is occur in incidence of 20% and carry mortality of 50%. The arrhythmia occur in incidence of 44%. The thromboembolism incidence is 20% with a mortality of 30%. Stroke, it's happens in 3% with carry mortality of 30%. And this can be extended beyond the acute onset of the acute COVID infection. And in one study of a cohort study, it's very recent study, just a few months ago, and the large wide cohort study conducted on 48 million adults in England and Wales. It shows that ventral thrombosis is almost remains for almost a year after COVID-19 infection. The cardiovascular complication of COVID-19 infection, including cerebrovascular problems, arrhythmia, inflammatory heart disease, ischemic heart disease, other cardiac disorders, thrombotic disorders, major adverse effects, are not only in hospitalized patients, it can occur in substantial number of patients in non-hospitalized patients. And this even can be more in patients admitted with the intensive care. On the other hand, what about the cardiovascular complication of coronavirus disease vaccine? As all we know, we have 4 vaccines approved in Iraq: the Pfizer one, the Sputnik, the AstraZeneca, and the Sinopharm. The messenger RNA vaccination, like the Pfizer, the main complication are myocarditis, thrombosis, and the thrombocytopenia in form of ITP or the acquired thrombotic tear. The adenovirus vector vaccine, like the AstraZeneca, can cause thrombosis with thrombocytopenia, the TS, and can be complicated by the vaccine-induced immune thrombocytopenia. The inactivated vaccine, like Sinopharm, it can be complicated by type 1, the Townes syndrome, which is the acute coronary syndrome, as the hypersensitivity. Upon reviewing of the literature, more than one over the last 2 years, including the various complications, cardiovascular complication of vaccine, including myocarditis, thrombosis, ITP, ATTP. It is not a big issue, it seems to be, as you could see. It will not exceed more than 23 cases per 1 million, and even in less than 1 per million. So it is a rare complication. Next slide, please. 14. So it is a rare cardiovascular adverse effect associated with COVID vaccine, and mainly the myocarditis and ongoing, therefore, for the sake of time. The vaccine-induced immune thrombocytopenia, thrombotic thrombocytopenia, and the thrombosis, the myocarditis after COVID-19 vaccination, which mediated through the inflammatory response, symptom fact, it's 12.6 cases per million, and symptoms onset within days from the receipt of the second dose of messenger RNA vaccine. Male affected more than female. The clinical course usually mild and respond to medical treatment and supportive care. Also seen in patients infected with SARS-CoV-2, 450 cases per million in young female under 20 years of age. In one interesting recently published in JAC, the prognosis of those patients with vaccine-induced myocarditis is much better than as compared to those patients with the COVID. As you could see here, there is a much difference. The vaccine-induced immune thrombocytopenia, the certain fact it's estimated as 1 case per 100,000 dose of adenovirus vector vaccine. The onset is 4 to 28 days after receipt of the vaccine. Female of more commonly affected and require emergency evaluation and can carry high mortality. Another important syndrome, which is the post syndrome, which is a posterior orthostatic tachycardia syndrome. It is rare, but it's debilitated state. It's a key sign, usually after standing occur for 10 minutes. People experience a rapid heart rate increasing more than 30 beats per minute or heart rate more than 120. Other symptoms including fainting, dizziness, etc. The study also found increased prevalence among people who got COVID-19 vaccine but hadn't been infected before. People developed spots following infection 5 times more often than following vaccination. The message here is that while we are seeing a potential link between COVID-19 vaccination and post-syndrome, the prevention of COVID-19 through vaccination is still the best way to reduce the a statement from the ACC that there was no evidence of an association between the mRNA-based Pfizer or Moderna vaccine and acute myocardial infarction, stroke, or pulmonary embolism in the 3 weeks after each of the first 2 doses. And the other important thing there was a slight increase in the risk of pulmonary embolism with Oxford AstraZeneca vaccine and for acute myocardial infarction with the 2 adenovirus-based vaccine, the AstraZeneca. But despite that, vaccination, including with adenovirus vaccination, could also decrease the risk of the cerebrovascular event, limiting the consequences of the potential. Another statement from the ASC that COVID vaccination are safe for patients with cardiovascular disease. The latest update just a few days ago from the CDC, which are an update for vaccinated people who received an update of COVID-19 vaccine were 14 times less likely to die compared with those who received no vaccine, and 3 times less likely to die compared with those who received only the original COVID-19 vaccine. So in conclusion, vaccine to prevent the SARS-CoV infection is considered the most promising approach, and the vaccine has been associated with possible thrombosis, thrombocytopenia, and for myocarditis. But the risk of these events are extremely small, and the benefit of all of these vaccines outweighs the risk because of the waning immunity and decreased vaccine efficacy against circulating variants. Public health authorities in many countries have recommended booster vaccine after the primary series. And thank you.
The last slide will be given by Dr. Tashmi, please.
Thank you, Dr. Safa. Thank you to inviting me to share my slide with this community, Royal College of Physicians London members and fellows and dear guests and dear undergraduate and postgraduate students. My talk is very simple, actually. I will not go through the cellular level like Dr. Zana. I would like to talk a few words about the COVID-19. We are unfortunate that in the last 3 years we face a pandemic, and every 100 years we have a pandemic. So we are unfortunate actually, but we will never give up, inshallah. The last the last update on the occurrence of the COVID-19 worldwide, we have more than 678 million coronavirus recorded worldwide, and we have more than 6 million deaths, unfortunately, in the last 3 years, and we have more than 650 million recoveries. The preliminary reports were at the beginning, which was taken from the COVID-19, that there was a large number, huge number of them. Their symptoms and signs remain after 2 weeks, and this was called post-COVID syndrome or long COVID syndrome. So the preliminary reports indicated some patients may develop so-called post-acute COVID-19 syndrome, in which they experience persistent symptoms after recovering from their initial illness. The syndrome appears to affect those with mild as well as those with moderate and severe cases. And Dr. Safa's patient and what have been mentioned, all these enter to this category of post-COVID syndrome and complication. In a series which was done in Wuhan, which was the origin of the COVID-19, unfortunately, in China, and spread from there to here, in 2019, it started at the last month and come to us at February and March, reached to us worldwide. And they do a study from January 7th to May 29th, 2020. They found that 76% of all patients had at least one of the listed symptoms. Fatigue, muscle weakness, more than 60%. Next, please. Difficulty in sleeping in quarter of them, loss of air in 1/5 of them, difficulty with smell and taste in around 10%, and trouble with mobility in 7%, and respiratory symptom in a different percentage of them, and cardiac problem in, as Dr. Muzaffar said, 1/5, maybe 20-23%, and a neurological problem, which is also a good percentage, and neurological problem, Dr. Safa more experienced to tell us how much they are. So we have a lot of post-COVID syndrome in all systems. In another series which had collected in Michigan, 38 hospitals in 1,648 patients, they found that about 1,250 patients survived, 975, 78% went home. Post-COVID syndrome was seen as cardiopulmonary symptoms such as cough and dyspnea, persistent loss of taste or smell, new or worsening difficulty completing activities of daily living, so cognitive dysfunction, and emotionally affected by their health. So there was psychiatric problem, some sort care of mental health after discharge. Some may have dementia also. So it is the persistent symptoms in patients after acute COVID syndrome by a study done in Italy. They found 143 COVID-19 patients in Italy with 56% had 3 or more persistent symptoms. Most commonly reported symptoms are fatigue, dyspnea, arthralgia, and chest pain. If we look to this famous chart, which was published in BBC, you see the common symptoms of COVID-19 after 2 weeks. After recovery, we have some of them remain in good percentage of them, like fatigue, restlessness, joint pain, chest pain, vision problem, cough, etc. So as you see, we are facing a pandemic of post-COVID syndrome after the pandemic of COVID-19. And in this picture also, we see a lot of problems which affect all systems of the body. If you look, we have 44% headache, we have insomnia, we have loss of air, we have joint pain, we have renal, cardiovascular, CNS, etc., with different percentages. So it is a big burden on the health of the humanity. This pandemic, unfortunately, it passed, and we overcome it by a vaccine program. This picture is a patient, Iraqi patient, sent by one of my colleagues with vasculitis with COVID syndrome. He took the picture and sent it to me, and I want to share with you.
And sometimes this may mimic other differential diagnoses, like cerebral like other types of vasculitis. Here, how we approach. Actually, most of our colleagues talk a lot about the approach in cardiovascular system and nephrology and pulmonology and neurology. Suppose in the future coming sessions we'll talk about neurological complication. We should have a good full history and examination and evaluation and investigation and approach. I don't want to bother you because you are tired from long session. These are the approach to how to deal with COVID syndrome, and I am ready to share it with you if you want to through Bashar. And lastly, I would like to thank you for your attendance and your participation. Thank you very much.
Thank you, Dr. Dishti, our colleagues, which has been shown some few slides and for the very interesting review of post-COVID syndrome having represented an acute kidney injury, heart involvement, pneumonia, and perhaps many psychological, psychosocial, healthcare associated problems that many physicians and health researchers are putting some guidelines to treat these comorbid conditions after COVID. Still not, we are not out of the area, as the professor said. We are now seeing the post-COVID syndromes. So you should take care of that. And almost in the history, as Dr. Hilal asked even Dr. Muhammad that anyone in the family that the same post-COVID problem, a routine asking for vaccination, date of vaccination, type of vaccination, follow-up, and the major features has happened because many patients now are claiming their long-term deficit, probably you've got low-grade myopathy, postural hypertension, postural tachycardia. Still, the patients are claiming either the vaccine or the acute infection causes persistent disability. A very interesting field. We don't have a straight guideline to diagnose them. We don't have a straight guideline to treat them. And there is no evidence-based pathological conditions with COVID that prove 100% it's associated with. But there are a few cases clearly that they develop their major organ involvement with the acute infection. So I'm just.
دكتور صفاء دكتور محمد عمر عنده مداخلة.
Please.
دكتور محمد عمر تفضل. He is raising his hand.
Thank you very much, Ustad Hilal. Do you hear me?
Yes, you are clear.
Thank you very much for this nice scientific meeting. Thanks for RCP Iraq London, and in this nice holiday Friday we are gathering together. Thanks for the speaker, especially Ustad Safa Al Muktar, Ustad Mudaffar Al Barzani, Ustad Zana and Rafid and Dashti Bustani, my colleagues and all attendees. Good afternoon. Again, thank you very much for organizing this nice scientific talk. It was very interesting and it was a very good review about the COVID and one of the complications. I have one question and few comments. Regarding the management of this case presented especially by the nephrology part by Safa, yes, the treatment is okay by pulse steroid and cyclophosphamide, but we should not forget the long or a lot of side effects by these drug, immunosuppressive drug. So another option is the adalimumab or the mycophenolate. The other point is that in the last slide of the presentation, as I noticed, the PCR for COVID was negative. So I didn't understand that this case was proved to be COVID or not, because I think the PCR was negative. And my last other comment is just for academic purpose, because the estimate. Yes,
Yes,
pardon? Yes, okay. So the other point is what is interesting is now academically one of the update in the management of the crescentic glomerulonephritis is what's called human amniotic epithelial cell. It is a form of stem cell management, which is much superior. I know it is still in the experimental, but it's found to be proved and used, and it has a very good outcome without or very, very little side effect compared to this classical type of therapy, and definitely less risk of infection. Because the crescentic glomerulonephritis, as we know, the prognosis is not very good, and a good number has relapse, and a very good number go to end-stage renal disease, and they end their life on dialysis or they need transplant. So it was very interesting if you comment on human amniotic epithelial cell that act through mechanism of prostaglandin E2, interleukin 10, and T cell growth factor, etc. This was my thing. Of course, regarding the COVID, just if you allow me, we share only the gastroenterology was absent in this case. We have very, very interesting cases. Inshallah, we will present. شكرا أستاذ هلال. شكرا for my colleagues.
عندك تعقيب دكتور صفاء؟
Sorry, and Mr. Hilal, thank you, Professor Muhammad, for the question and for the comments. I think the use of amniotic fluid as a stem cell precursor or a local vasodilator for the capillaries is not tried only in ankle-associated vasculitis. It's mentioned for other diseases involving the vascular system. There are reports of using it scleroderma renal crisis, which was very effective. You know that scleroderma renal crisis is a state of vasoconstriction. Many vasoconstrictors are upregulated, and the use of this approach is still investigational. And I think the CJSON in 2022, there was an animal model depleted of certain vasoconstrictors and amniotic fluid by causing local vasodilatation. Many cases of acute glomerulonephritis has been reversed. What's new in the management, Mr. Muhammad, in the management of ankle-associated vasculitis is the use of complement 5 convertase inhibitors, avocopan. It's came FDA approved for the management of oral treatment for the complement factor 5 convertase. Avocopan is the lastly mentioned drug, and the other interesting new drug is pegcetacoplan, which is a directly C3 inhibitor, knowing that the role of complements causing damage to different organs, including the kidney. Thank you, Professor Muhammad. Thank you.
دكتور صفاء إذا تسمح لي دكتور صفاء تسمعني؟
نعم وياك أستاذ.
شكرا جزيلا على الاكسلنت برزنتيشن والاتشيفمنت بهاي الكيس. The idea is that to have multiple specialities dealing with one patient in a multidisciplinary team. يعني شكري جزيل استاذ مظفر، استاذ رافد، استاذ دشتي، دكتور زانا، دكتور محمد سامي، your assistant حقيقة للتحضير لهذا السيشن. سؤالي اللي طرحها دكتور رافد كان كلش براكتيكال حقيقة، الفاكسين والخوف مالته والبوستر دوز والمرضى اللي يحجون عليه دائما. The other point is that I want to share with you experience of those patients اللي هم post COVID دكتور دشتي، اللي هم asymptomatic, completely healthy, but their investigation showed the D-dimer is still high, and this causing some phobia and some obsession to many patients. They are fully asymptomatic, but their investigation persistently showing a high D-dimer test. What do you think about those patients? What do you suggest for their approach? And thank you.
Thank you, sir.
نشتي عيني لو تطاوع علينا بالمقلوبة حتى نشوفك. برا الكاميرا.
Thank you, Sir Hilal, for your nice question. Actually, I always tell my students that don't read papers of investigation. As far as the D-dimer is high and there is no risk of thrombosis, there is no need for antiplatelets, heparin, etc. Unless you have other risk factors,
and the patient healthy, don't give, to my limited opinion, knowledge or experience, I will not give such treatment to investigations. Thank you.
Thank you very much. دكتور مظفر، دكتور رافد، عندكم أي suggestion على هيك مرضى شايفين وشلون تتعاملون وياهم؟ أستاذ مظفر.
Thank you, Ustaz Hilal Safar. Really, we daily see patients coming to us. They are complaining from their D-dimer, they are afraid from D-dimer. And unfortunately, the paramedics usually they obsess. This is the point. And usually we advise him to not to afraid from the D-dimer only. We use it to exclude when it's a negative, it's important, not when it's positive. Thank you.
Thank you. Thank you very much.
I have the same opinion because we are not treating exactly. We are not treating lab figure all the time. This is not applied on COVID. It's applied everywhere. And really, you raise a very important point in our day-to-day practice. Most of the time, they are coming. I don't know. They will do. You are not requesting D-dimer for those patients. They will do with the lab. They are coming with D-dimer, and they are showing us that their D-dimer, and they are telling us, please give me a treatment. I want this to be reduced. So we are puzzled with this. We are trying to convince those patients, don't take anything. Go and as far as you are asymptomatic, you have nothing. Go and just reassure them, and they give. We let them go without we are not giving them any treatment.
One year after active infection, no CRP and normal transferrin saturation. The normal transferrin saturation excludes iron deficiency, and the 13 will still low for months. I don't know why. I have seen many patients with a low CRP, normal transferrin saturation post-COVID, and he's claiming that his anemia is a chronic disease. But I think that my COVID is a chronic one. I need to comment? No? So there is many symptoms post-COVID that I don't know how to answer them. I think that CRP still in some patients run away between 300 and 600 for weeks or months. And I don't think that it should be specifically treated unless there is an indication or a hands for most patients.
Probably, Safa, it is a call for our postgraduate trainee to go and search for those patients with abnormal parameters, not only D-dimers. Any abnormal parameter as a part of follow-up of those patients, like Dr. Deshti was addressing, is that the post-COVID sequelae. And we try to find any case reports everywhere and what is the experience of others. I think it's very good for our trainee to follow these issues.
Okay, for the sake of time, we want to end this session with you, sir. And thank you as the chair of our CP Iraq network, Dr. Hilal. Yes, we have another last question, please.
خلي الشباب شوي نسمع منهم.
Thank you so much, dear doctor, for this nice presentation.
ممكن تقدم نفسك. Present yourself يا زحمة عليك.
Your name and your
specialty.
This is Mustafa, fourth-year medical student from Asian College of Medicine. As in the history mentioned, the patient was previously normotensive patients, but in the echo, it revealed that the patient has LVH. So it may be clue for the undiagnosed hypertension.
Yes,
yeah. So my question,
yes.
my question is regarding the differential diagnosis.
Oh.
So why all differential diagnosis was related to the vaccine-induced or let's say COVID-induced? Why it's not about the hypertension-induced renal injury? So as undergraduate student.
Yeah, one was still coming to the fifth stage just to teach you. The kidneys are usually involved by hypertension. A very interesting question. Sudden severe hypertension can decompensate the kidney, the heart, the eye, and the urine. So, syndromes of severe hypertension, renovascular hypertension, preeclampsia, scleroderma renal crisis are classical examples of a rapid rise in the blood pressure. This may decompensate the kidneys in the form of acute non-proteinuric kidney disease. There will be a fibrinoid necrosis in the glomeruli. like what's happening in the brain in hypertensive encephalopathy, or what's occurring in the myocardium as a fibrinoid necrosis of the capillaries. So the term of fibrinoid necrosis or endothelial injury acute in hypertension is not the scenario that you are seeing here. Is not the scenario. You will not have a urine exam containing RBC or RBC casts in hypertension-induced kidney injury. You will not see this rapid deterioration of kidney function. Patient usually will not reach dialysis in that few days. So a very interesting suggestion that acute severe hypertension, not the chronic one, maybe to acute kidney injury in the form of acute glomerulonephritis, but not necessarily with hematuria and other signs of inflammation. Okay, okay. Another question by the students, colleagues? Okay.
Thank you very much, Dr. Safa, for your hard effort in preparing this patient scenario, and my thanks extended to our distinguished professors and consultants. During the coming few days, we will have a program of training for the PACES examination MRCP. These courses will be online. All the links are there on the Facebook page and the website of the RCP Iraq network. And as I have just said at the beginning, it's most welcome for any suggestion, any contribution, any activity in the future. And thank you all. صفاء نشوفكم على خير، وفعلا سعيدين بهذا السيشن اللي يكون الأول من هاولير. دائما activities نتابعها تكون high quality وتكون حقيقة دسمة، بها content مفيدة للundergraduate as well as trainees as well as for consultant. أنا شخصيا تعلمت منكم اليوم، وشكرا جزيلا لجهودكم ولتقديمكم، ونشوفكم إن شاء الله على خير بالنشاط القادم.